Is there a familial component to it?
We do see a familiar component to some of our autoimmune diseases. Lupus is one, rheumatoid is another. Again, it's not like a one to one. Just because mommy or grandma had it doesn't always mean that you will have it. A family history is key.
Hi, this is the Care Room with Dr. Cindy. Welcome. It's a space that was created just for you. I'm your host, Dr. Cindy, and this is a chance to get up close and personal with me. We're going to talk about the things in medicine that matter to you. We'll talk about the questions you've been carrying. We're going to have some honest conversations. We're going to hold space for joy, struggles, and everything in between. It's care that goes beyond the exam room. Care you're going to take home with you, whether you're listening while you're driving or you're listening while you're exercising. I promise that it's going to be care that's rooted in truth and a deep commitment to walking with you every step of the way. I'm glad you're here. Well, hello, hello, hello. Hi, everyone. Welcome, welcome, welcome. Welcome to another episode of the Care Room with Dr. Cindy. Today, I have a very special guest. I know I say this all the time, but we are all special.
Yeah.
This person is a really good friend of mine. She is Dr. Fran Okoye. She is joining us all the way from Maryland. So
Mm.
I really, 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 really appreciate this sacrifice that she's doing for me today. But before we get into everything, I'm just going to let her introduce herself.
Hi, everyone. I'm Francesca Okoye. I'm by way of Baltimore, Maryland. So I've actually know Dr. Ojiwe from being in Pennsylvania because I was there for 8 years. Yay! But I'm back home because my whole family is pretty much on this side of the
Yeah.
pond.
Yeah. Do you like it being back home?
I love it. I'm a city girl at heart.
Yeah.
Yes.
Yeah. And Dr. Okoye, can you tell us how you serve the patients of Baltimore, Maryland?
Yes, so I am a practicing rheumatologist for adult rheumatology.
Okay.
I see pretty much general rheumatology, but I do have a passion for certain subsets of rheumatology. I still have my internal medicine hat on, so
Nice.
I don't ignore basic things that I see in clinics. So yeah, I'm MD PhD, and I do uh, dabble in helping internal medicine questions as well.
Sure, sure. And I know you have this really nice pedigree. And guys, by pedigree, I mean like where she trained. Can you tell us more? Because you are some big.
I did my med school at University of Maryland. I jumped into the MD PhD world, and I have a PhD in T cell signaling. So I did immunology for 5 years and then jet set to the West Coast for Stanford to do my residency. After that, I came back to the East Coast and went to do my fellowship at Hopkins.
Yes.
So that I have been running around back and forth, but I'm back. Glad to be on the East Coast again.
Yeah. So, guys, she's all that means is she's really, really smart and she spent a lot of years studying. So, she really knows her stuff. We really value her recommendations and opinions. And today she's here to talk to us about lupus. So, I'm sure you guys have all heard it. A lot of, people probably have heard, a lot of celebrities having lupus. And we all wonder, like, okay, what is this really about? I know, like, I think even before like the medical field was on my horizon and where I actually learned things, in the media growing up with like Tony Braxton, and hearing, like, oh, she has lupus. But yeah, Dr. Okoye is here to shed some light on that for us. So Dr. Okoye, can you tell us what is lupus?
Lupus is one of those diseases that can appear in so many manifestations. So oftentimes that's why it's often difficult to diagnose. So, some patients, and it can do anything. I think it's not the great mimicker, but honestly, it's a disease that can manifest in a variety of ways from something as tangible as photosensitive rash, mouth sores, hair loss, and 9 times out of 10, patients with lupus have fatigue. Two, it can cause joint damage. internal organ involvement where it can destroy the kidneys if we're not treated early, to even affect the heart if, again, not caught on time. So it is one of those diseases that it can has a lot of what we call clinical features, but can also look like other common things that people deal with: fatigue, joint pain, hair loss. That can be anything from your thyroid to,
Right.
are you reacting to a medicine or a virus that you have? So it's one of those diseases that has been really hard to kind of tease out. And yes, we get a lot of referrals, and the number one referral and reason we get is that test that people get, an ANA,
Okay.
anti-nuclear antibody. For my internal medicine colleagues, this ANA test is kind of one of our sticking points in rheumatology.
Right. Right.
And so we get a lot of referrals. So somebody has a positive ANA, they're told that they have lupus. And with us, we then have to go in and get the history, get the exam, and kind of put the picture together to say, is this patient who has fatigue and joint pain and brain fog with an ANA, is this lupus or is this something else?
So are you saying that do you want us to get the ANA? Like if we're thinking us, primary care doctors, if we're thinking, yeah, this patient, they might have lupus. I should order an ANA. Is that something you guys want? Or are you saying we should not?
I am saying your clinical suspicion should guide a blood test, because I can make a case for an ANA. 20% of healthy people have a positive ANA.
Me.
30 million Americans walking around on ANA. They don't got no lupus. So it's, what is the patient telling you?
Right.
If you have a young woman of childbearing age, that's our big kind of class of patients, we see it.
Okay.
And she comes to you and she says, my joints have been bothersome. I have morning stiffness lasting more than an hour or two. I know I'm tired all the time. My sleep is okay, but I'm noticing that my hair is falling out and I have mouth sores. Those are big keys.
Right. Okay.
And then that's kind of should prompt you to go, let's check her thyroid, make sure her vitamin D is okay. When you do a basic CBC, is she anemic? That's not good. Again, common things being common, iron deficiency anemia in women because of our menstruation. But are there any other abnormalities in her blood work? Are her white counts suddenly low and she doesn't have an infection? Those are the key clinical and laboratory features that should trigger an ANA. But
Got it.
if, let's say, a 25-year-old comes to you and she says, my main complaint is joint pain, I'm stiff, I know I'm an athlete, but this is ridiculous. Or clinical, with nothing else, just joint pain and fatigue, I do a rheumatoid factor and anti-CCP. I don't go down the route for an ANA because, like I said, it's very sensitive but not specific
Got
for
it.
lupus.
Got it. So, for the patient listening, thinking, oh, I might have lupus, what does lupus look like? What should prompt them to go to their doctor?
So, like I said, unfortunately, it can look like a lot of things.
Yeah. Okay.
Common things being common.
So, joint pain.
Usually what I've seen come through the door that's, oh, I don't even have to do a blood test and I just sit there and say, yeah, this patient has lupus,
Yeah.
is I've found that most patients with lupus kind of minimize their symptoms. It's kind of interesting. They kind of focus on non-specific stuff. So my patients with lupus will have rashes that kind of, if they've gone to dermatology, kind of is something that we say it's photosensitive, meaning when you're outside in the sun,
It
that
gets
will trigger a very classic rash. Doesn't have to be that butterfly rash, but it can be rashes on your arms. Often lupus patients will really complain about the hair loss, and not just I'm combing my hair and it fell out. It's patches of kind of hair loss. But again, it's kind of something that they blow off and just attribute it to stress or attribute it to, maybe thinking that it's a thyroid issue, although they've never had that tested. So, and then the mouth sores, I've seen that. Fatigue is a big non-specific kind of symptom that we see in a lot of conditions. But the fatigue is a different. They will tell you it's different from kind of the fatigue that they're used to having during their menses or they're used to having to other in other conditions. But often my lupus patients are I know there's something wrong. I've kind of changed my stuff, but there's something else going on. And they often will minimize their symptoms because not attributing it to an autoimmune process.
Dr. Okoye, you're talking and I'm like, geez, I'm so tired all the time. I have joint pain. I just turned, I just, and well, I'm in my 40s and, my hair is falling out. Like every time I comb, even though, anyway, that's a whole different story.
Well, I will tell you, yes, this is another age group where it's the older woman in her
Yeah,
40s, 50s, menses are a little
perimenopausal.
off,
Yeah,
our sleep cycle's a mess.
yes.
I will say that group, I get a lot of referrals for that, and somebody gets an ANA and it's positive, and I'm
Positive.
like, "Well, is your periods regular?
Yeah,
Are you
got
waking
it.
up at 3 a.m.?" And then, of course, we go down the path and doing the more specific autoantibodies that I need to see. So it's a small subset of these and 50s kind of perimenopausal, postmenopausal women that I catch it. But often it's the younger women that it's kind of that's more the lupus section versus the older individual where we often catch Sjogren's, you know, and patients with Sjogren's have a positive ANA. So we
Okay,
do want the ANA, but I need a tangible reason for that because I get, again, a lot of my ANAs 1 to 80, and my doctor told me I had lupus, and I'm like, "Well, tell me what's going on. Why was the test done?"
sure.
You know? I do not like when people say, "Well, it's routine." It's not a routine test.
Got it.
Okay, and it shouldn't be because, like I said, 20% of healthy people have this blood test, so we need to have a clinical suspicion before we just order an ANA.
Agreed, agreed. So for those who get the diagnosis, I guess the other 80% of those with the positive ANA who do come back
Mhm,
positive or whatever percentage for
mhm.
lupus, right? But what does life look like for those patients in terms of treatment? What can they expect with like lifespan? Is this like a terminal diagnosis? Can you shed some light on that?
So I wouldn't say it's terminal. I often say any rheumatologic condition is lifelong.
Okay.
Something turned on your immune system to attack you. And
Yeah.
my job is to turn down that heat. My
Okay.
job is to turn it down to the point that it stops messing with you, but your immune system can still protect you from the day to day outside onslaught of bacteria, viruses, and crazy stuff. So there's been a lot of advancement in lupus treatment, which is awesome. Back in the day, it was just prednisone and lots of aspirin and plaquenil. Now we have a variety of meds. Prednisone we love, but we hate as well because it has a million side effects. So the mainstay of lupus treatment is hydroxychloroquine.
Okay.
I was taught that if you put it in the water, half the people will feel great because it's a great. It's great for joint pain. It's great for the fatigue. It's great for inflammatory rashes. We certainly use it to treat rheumatoid arthritis patients, and it has a really good side effect profile
Sure.
versus the other medicines that you've heard about. Every 2 minutes now we're getting new biologics, which are what we call targeted therapies for lupus patients. Benlysta has been around for now, what, 10, 11 years now. We just have Safonella, which is an infusion. There's newer medicines for lupus nephritis. So our armamentarium is growing, which is awesome. So it's a treatable disease.
Sure.
We want you to get better. We want you to live your life. And yes, you have lupus, but lupus should not define you and it should not prevent you from having a full life. So that's the good news.
And lupus, like you mentioned, it can affect different parts of like different organ systems, right?
Yes.
Like your hair, your skin, your kidneys.
hmm
Can you shed some more light on that?
Yeah, so often the dreaded concern is the internal organ involvement, lupus nephritis. We're often that is one of the scariest part of having, lupus is it going to affect my internal organs? So we monitor. There are ways we look. We check your urine, make sure you're not spilling protein in your blood. If we see there's a change in that because we're often monitoring that every 3 to 6 months. If we see any change of lupus activity, we get a biopsy, we start to treat. We probably even start to treat before the biopsy because we know time is of the essence. We want to save your kidneys. We want to make sure that the internal organs are not affected. We do routine lab monitoring for lupus patients, and that's how we kind of make sure that it's not causing internal organ damage. We watch our meds that we give. Prednisone is great, but long-term use causes cardiovascular disease, can cause diabetes, can cause glaucoma. So it's our fastest working drug in rheumatology, but it's has so many side effects that we are always wanting to minimize the use of it if we can.
Yeah. Yeah. And my understanding is that it's like an up and down. You have lupus flares and then you get better. So for the person living with that, how can you minimize like the flares?
Right? So I always say meds don't work if you don't take them.
Right?
It's so weird because that's another thing I see in my patients that, oh, I'm feeling better, so I don't need this medicine anymore. No, you're feeling better because you're on the medicine. So please take it. So that's one of the interesting features of lupus patients that they
Yeah.
feel better and they're like, oh, I don't need this anymore. Like again, I say, I'm putting you in remission. I'm trying to get that lid from blowing off or the fire from reigniting. The meds are helpful. So to prevent the flare ups, you need to stay on your medications. The one that is one of our long-term medicines is the hydroxychloroquine. Is shown in clinical trials to prevent lupus flares, prevent internal organ involvement. So that's the number one drug that I need you to be on pretty much lifetime if I can get away with it. There's a rare side effect that it can affect the vision. So we have patients going to the ophthalmologist or optometrist and getting yearly eye exams to monitor for that side effect. And 9 times out of 10, if we see any changes, stopping the drug kind of reverses or halts that side effect to the vision. But otherwise, it doesn't require routine lab monitoring. It doesn't suppress your immune system. It just changes the way it talks to itself. So that's how we try to prevent flare ups. We tell you to eat healthy, reduce stress, sleep, and exercise, and take your meds.
Okay.
But if you do flare, again, we have a short-term course of steroids. If the flare-ups are just more frequent and the hydroxychloroquine is not enough to keep your lupus under control, then we escalate therapy by adding more medications to get you back in remission or under control.
Got it. Got it. Is there a familial component to it?
Great question. We do see a familiar component to some of our autoimmune diseases. Lupus is one, rheumatoid is another. But again, it's not like a one to one. Just because mommy or grandma had it doesn't always mean that you will have it. So a family history is key. I take a detailed family history for any of my rheumatology patients that I see. Because yeah, it's that clinical suspicion. So I've had patients come in and say, well, grandma had lupus and my sister has lupus. But again, let me know what you're dealing with and then with what your symptoms are and your kind of blood work looks like, then we can go from there. But yes, there is kind of a genetic component to certain autoimmune diseases.
Oh my gosh. Thank you. Thank you, Dr. Okoye. Thanks for shedding some light on that for us today.
Of course.
If one of our listeners who's been listening and they like what they heard, they want to get in touch with you, where can they find you?
I work at Mercy Medical Center. So I'm a rheumatologist at the Rheumatology Associates at mdmercy.com. So you can just Google and
Google
you
is
can
always
get in
our
touch.
friend. Yes.
What was that?
I said Google is always our friend.
Yes, yes. So you can just find our office information and get in touch, and then we'll certainly take a look and see what's going on. We do request referral records. We do request, again, if there's a clinical suspicion for an autoimmune process, labs would be nice, okay? And so why should I get an ANA?
Yes, yes.
Because I have symptoms. I have joint pain that doesn't get better with Tylenol or Aleve or Motrin. I have joint swelling. I get crazy rashes, mouth sores, unexplained fevers. And then, you go to your primary, they do a good workup. And if something lights up that's inflammatory or autoimmune, come on down. We got you.
Yeah, yeah. Well, thank you. Thank you for sharing that with us. I'm sure, yeah, sure that will be helpful to a lot of people listening. We do appreciate your time. As I mentioned,
Of
you're
course.
always welcome back. But as always, guys, take a listen, go check out Dr. Okoye. But thank you again. And guys, next time I'll have another awesome doc on. But until then, take care. Bye.
Thanks for spending time in the care room today with Dr. Cindy. If you liked what you heard, please subscribe, share this podcast. I'm also on Facebook and Instagram. You can follow me there. Remember, you're not alone in this. There are doctors who do care. The information in this podcast is for educational and informational purposes only. It is not a substitute for professional medical advice, treatment, or diagnosis. Always consult your personalized healthcare provider for medical guidance.